As we move into this unit of the axial skeleton, we start at the most superior aspect, which is looking at the jaw and the muscles of mastication, so looking at chewing and eating. And it's the temporomandibular joint, the TMJ, and there's only one joint in this whole region, and it's involved with the opening and closing of the jaw. There's some accessory movements like protraction and retraction, but they all support this opening and closing perspective. Outside of the jaw, there's not a lot of moving parts within the head. The head moves as one functional unit, and it's controlled usually mostly by the cervical spine at the C1, C2, and C0, C1 aspect. But when we look at the joint here, we're looking at this one particular joint, the TMJ, temporomandibular joint, and that is made up by the mandible and the temporal bone of the skull. The muscles that are involved in here lay in the temporal fossa that are made up of the sphenoid, and then we have some interaction with the zygomatic bone, with that zygomatic arch, and then some of the supporting musculature is involved in the maxial bone, so we're looking at like facial structure. And just to round it off, you have three other bones in the skull. You have the frontal bone, the parietal, and then the occipital bone, which we'll talk quite a bit about when we get into the next unit when we look at the cervical spine. If we look at the jaw itself, the mandible, you have some of the unique anatomical landmarks here. You have the condyle, which makes up the primary joint, the articulating surfaces. Then you have the coronoid process, which is the attachment site for the temporalis, as we'll find later. You have the ramus, the body, the angle, and different components. You can kind of see the bilateral component of that condyle. But the condyle here really is the articulating surface that articulates with that temporal bone that we saw earlier. One of the unique aspects of the skull that's sometimes unappreciated in the two-dimensional, or at least three-dimensional, but one singular planar view that we have is the zygomatic arch. And if we look at this from a different perspective, you'll see that there's openings within the skull, and you can put a string right through there. And what that really serves as the purpose is the better angle of pull through the temporalis muscle. So the temporalis muscle is going behind the zygomatic arch down on that coronoid process, and you kind of see here that opening right here. You can see the belly of the muscle and the tendon coming down and attaching to that coronoid process. And as I highlight here, that is open space through that. You have another bone that is not part of the skeletal system itself. It's part of the skeletal system, but it's not directly attached, as the hyoid bone. And this serves as an anchor point for the musculature that's underneath the chin and below the chin. So you have your suprahyoid muscles and your infrahyoid muscles, as we'll explore a little bit. Right here is the thyroid cartilage, so part of the Adam's apple. So that sometimes is misconstrued with that, but there's your landmark for the hyoid bone. And just to kind of give you some reference here, you can see the hyoid, you can see the epiglottis and the thyroid cartilage. So it sits right below the chin, high up on the neck, right in front of C2, C3. So that's our joint there. We have the TMJ, you have the condyle of the mandible, and then you have this fossa of the temporal bone. And it's different than most joints, as we'll see. It's unique that the cartilage that usually is between joints to aid with lubrication and compression is not adhered or fixed to any of the structures. It's kind of a moving aspect to kind of more of a dynamic joint. But you can see the highlighted areas here. You can see where the muscles originate and insert. Obviously the bottom jaw set of teeth. This is where all of our attention is going to be, is in this posterior, superior aspect of the mandible. This view here is looking at an inferior view from the side, and here's that zygomatic arch. Here's the top part of the molars, and then there's that temporalis space that's there, so you can actually see through that. Then you can see some of the attachments here, the masseter muscle, which is the largest muscle for elevation of the jaw, so closing of the mouth, and then we'll look at some of these other components. But what I really want to point out is this dome-like function here. This is the joint space here, and then there's the mandible, and that's the articulating surfaces between these two aspects there. So that was what I was highlighting there is the temporalis, the temporal bone of the skull. And as we zoom in here, we'll look and see that there's a area that is that articulates with the mandible, and that dome of that surface articulates with the condyle, and that's what makes up the joint. So both of these condyles on both sides, that's the articulating bone with the skull. And you can see here that here's the condyle, there's that dome of the temporal bone, and then here's your joint disc here. It's almost like a vertebral disc, and it acts as a cushion between these two aspects because the amount of force that's being generated here is quite large, and it's a small area. This disc is crucial to the movement, the fluid movement of the depression, opening of the mouth, or elevation, closing of the mouth. And you kind of see the joint capsule here. You can see the space that's there, and you can see that this disc is not quite adhered to either the anterior the superior inferior surfaces. And we'll see with some of our slides here that the disc is designed to move to accommodate the jaw. This is an image from your textbook looking at that cross-sectional area, and you can see that there's a space. It's almost sandwiched between the two bones, and you have this disc here. When you look on the outside, you have the connective tissue, you have the joint capsule, and so it would look like any other diarthrosis or regular joint. So what's interesting here with the way that this joint is designed is here's your condyle of the mandible, there's your temporal bone, there's that disc, and part of these tissues are connected to the lateral pterygoid, particularly the superior fibers. And during opening or closing, what's happening is this disc, as the jaw opens up, let me go forward one slide. As the jaw opens up, you can see there's an anterior translation of that jaw. The compressive forces don't change. This is the resting position back here, but as it opens up, there's quite a bit, almost like 2 centimeters or so of translation, maybe 1 or 2 centimeters of anterior translation that happens with that. So what has to happen is, in order for this to be a cushion, as this opens up, this is going to move forward. This disc has to come along with it. And that's what these superior fibers of the lateral pterygoid muscle is doing, as we'll see in a later slide, is that as these generate tension, this is being pulled out, almost thinking like being a rug following you where you're going, or like a mat that's following you on the floor, that you keeps this really nice congruency between the condyle, and that disc moves as this opens up. And so that's what makes this joint unique compared to other joints where the articular cartilage or the passive aspects and non-bony components are usually adhered in place and are accommodating. Like think of your labrum of the shoulder or the meniscus of the knees. Those aren't moving. If they move, there's usually a problem with that. Whereas this is meant to be mobile, and if it's not moving, as we'll see later, there's a problem with that. When you open your mouth, that's mandibular depression. And when you close your mouth, that's mandibular elevation. So you're closing, opening, and you're getting this associated anterior translation, which is called protraction, or posterior retraction. As we open up, you'll see that there was, if we go from this resting position here to this starting position here, there is quite a bit of anterior translation. And in the next slide here, we'll see that this translation and that disc has to accommodate that movement. This is controlled by the neuromuscular system. You have the protrusion here with the jaw coming forward. That's if you try to stick your teeth out, this is you doing an anterior translation without the mandibular depression. And you have retrusion, which is, and I said retraction earlier mistakenly, but retrusion where you're pulling the jaw back. But this is going to look like this, where you have this anterior translation similar to the opening, but you're not getting the opening up of the mouth. And then when you get the retrusion, it's coming back. This is controlled by the lateral pterygoid muscle. So there's one muscle that's in the mouth. There's a lateral and medial pterygoid. The superior head, you can see that it has its fibers connected to the articular disc, and the inferior head is involved in opening. So as this pulls this way, it's going to help open the mouth, and this slide here shows it better. As this pulls forward, it's going to help open the mouth. The inferior fibers are going to help with the anterior translation, and the superior fibers are going to pull on that disc, basically coordinated together, so as this is opening up, that disc can move freely and hopefully timed accordingly. What can happen over time due to postural instabilities or postural imbalances, muscle imbalances, you can have a disc coordination between these two, and you can also start to get some adhesions and other types of degeneration within that joint. So you have one other set of movements here. We look at lateral deviation, so that's moving your jaw to your left or to your right. And basically what's happening when you do that is, instead of when you do opening or closing, you're getting bilateral protrusion or bilateral retrusion. And in this case, this is going to be a unilateral protrusion on one side and basically retrusion on the other. And that's more in terms of what's happening mechanically, but also from a muscular participation perspective. So when you have your lateral deviation, you're going to have an anterior translation of the right side, so it's going to glide forward, and you're going to get a jamming up because there's really nowhere for this to go. This would normally want to go back, but it can't go back, so it spins instead. And see, that's how you get that distal end of the jaw to kind of go out laterally. And then the opposite is true. If I'm going to go right, lateral deviation, this is going to be jammed back. It's going to hit bony structure. This is going to open up, so you'll have your gliding there and spinning there. So that's really the three things you can do. You can either open your mouth, close your mouth. That's one set of movements. You can stick your jaw forward or bring it back. That's another set of movements. Or you can stick your jaw to the left or to the right. And that's basically it for TMJ movements.